And so I just want us to kind of hold on to all of these things because we're all here. We may have different sort of visions on how we get to places, but we all are here because we have a commitment to increasing the quality of life and encouraging our patients, clients, and community members to have better experiences and systems of care and to feel better overall. So we're all here with one basic thing in mind. So on that note, I'll tell you a little bit about myself. My name is Lydia Bartholow. I am a psychiatric nurse practitioner. I am the Associate Medical Director of Outpatient Substance Use Disorders at Central City Concern. And for those of you that don't know, Central City Concern is a fairly large homeless healthcare agency in Portland, Oregon. We primarily operate in downtown Portland, but we also have some clinics and services out in East Oregon. I'm also a person in long-term recovery. So when I talk about some of the topics today, it's not just academic for me, and it's not just because these are the patients I serve, but some of this is personal in terms of my own journey. So so this is a huge bummer. I wore something ridiculous so that I couldn't attach this to myself, so I'm actually trapped behind this today. So I apologize. If I don't move around, it's only for that reason. So I want to lay some numbers on you guys. What we know is that children who experience trauma are 4,600 times more likely to develop substance use disorders in adulthood. I want you guys to just sit with that number for a second. 4,600 times more likely. That's not like twice as much or 10 times as much. That's 4,600 times more likely. And because of that, which by the way, you don't see numbers like that in public health, you never see numbers that large in public health. So because of that, it transforms what we know about addiction and where we think addiction comes from. And I would say also because of that, one of the key things that we need to tackle, so if everyone in this room wants to improve the quality of life for patients, clients, and community members and themselves, we have to end the stigma. And we have to start with a better understanding of what actually causes substance use disorders in adulthood. So miniature agenda for today. Again, I often give this talk over like several hours and I'm squishing it down to about 30 minutes. Because of that, I'm gonna chunk out some of the science and shave off some of the science. I think Dr. Hart did a great job of that. But I wanna go into the ACEs a tiny bit because that's where we get that 4,600 number. So I want you guys to have context for understanding where that number comes from and what it actually means. And then we'll do a tiny little bit of neurobiology. We'll talk about how in trauma-informed care we conceptualize substance use disorders a little bit differently than sort of the classic hedonistic conceptualization of substance use disorders. And then finally, we'll talk about trauma-informed care. And when we talk about trauma-informed care, I'm gonna go a little bit beyond, sort of the SAMHSA conceptualization of basic tenets of trauma-informed care. And I'm gonna talk about some of the things that I think are central to creating changes in systems to better serve patients, given what we know about substance use disorders, specifically opiate use disorder. So let's start with talking about this basic connection between trauma and substance use disorders. And like I said, I wanted to mention a little bit about the ACEs study because that's where we get that 4,600 number. How many of you are familiar with the ACEs study? Okay, that's great. So I want to spend just a second here because I saw a couple people that didn't raise hands. So the ACEs study was a huge population-based study in Kaiser in the early 1990s. It happened in Southern California. And it was a doctor, Dr. Folletti, and he actually, no interest in trauma, no real interest in addiction, primary care doc. And what he was charged with tackling was obesity. And what he found was that people were able to lose weight, but then not able to keep the weight off. And what we actually know is that anytime you do caloric restriction, you're just gonna gain the weight back. That almost is universal. But at the time, what he did is he said, I'm gonna sit down and I'm gonna really investigate, I'm gonna do some qualitative studies with these folks and see what's going on for them. And what he discovered by really spending time listening to people was that overwhelmingly, people struggling with obesity in adulthood had traumatic childhoods. And so he started asking people these 9 basic questions. It was the questions that you see up here. So there's one about intimate partner violence. There was one about neglect, one about physical violence, one about sexual violence. He asked people, what did you experience in your life before the age of 18? And then he tracked what that looked like in terms of health outcomes in adulthood. And so what he found was that over and over again, the higher number of your ACEs score, so the more adverse experiences you had in childhood, the poorer your health outcomes were in adulthood. And if you look at the graphs that graph this out, every single one looks the same. So whether you're looking at alcohol use disorders, opiate use disorder, fibromyalgia, some specific autoimmune disorders, over and over again, you see that people that have higher ACEs scores have poorer health outcomes in adulthood. And again, these are numbers and correlations that you just don't really see anywhere else in public health. So people have developed a couple of sort of conceptualizations and theories about this. What we know is higher ACEs scores, poor health outcomes later in life. And there's a big sort of question in there. Is this because people adopt poor health behaviors, or is there something else going on? And we think it's probably a combination of both. So Dr. Hart spoke a little bit about the role of stress. And what we know is that chronic stress in childhood does something strange to your adrenal system, cortisol levels in adulthood, and there's a neurohormonal change in the way our body does inflammation, and that may have something directly related to dopamine levels, for example, in adulthood. So Dr. Hart just spent so much time talking about dopamine levels, and what we know is that high ACEs scores may actually mean that you come into adulthood with low dopamine. So you guys just tell me real quick, you come into adulthood with low dopamine because you've got a high ACEs score in childhood, and a doc gives you that first oxycodone for lower back pain. What's that oxycodone do differently for someone with a high ACEs score? You guys tell me.
Replenish the receptors.
What's that?
Reverse the receptors.
Replenish and reverse the receptors. And just like lots of folks can go out and have one bowl of ice cream, oh, that ice cream's pretty good, I feel satiated. One oxycodone when you came into adulthood with low dopamine receptors, no, that was great. That was the first time I've ever felt normal. Hey, could you give me some more of that? Or you're gonna take that away from me? I'm gonna find the cheapest way to replace it, right? All right, so we also know, and this is something that I usually spend quite a bit of time on, but we don't have enough time today, unfortunately. We also know that ACEs scores are really connected to social location. And this is where I talk a lot about structural violence. Are you guys familiar with this terminology of structural violence? Okay, so structural violence, basic concept, says that there are social structures that determine whether people get their basic needs met or not. What would those social structures be? Income inequity, racism, gender inequity. So when people come into my clinic and we talk about their trauma history, almost never is that trauma history a personal one or a specific one that doesn't exist in a larger social context. So people come into my clinic and they experience neglect in childhood. That neglect happened in part because their parents needed to work 2 jobs to ensure that they had housing. Or potentially that neglect happened because their parents were struggling with addiction and the social structures that have set up addiction treatment services weren't meeting those people. So I came to be thinking about this partially because I do a lot of public speaking, and I was on a relatively conservative talk show in Portland about opiate addiction, and they cut off something I said and then they inserted, Dr. Lydia Bartholow, I have a doctorate by the way, says, opiate addiction happens because of a personal problem. And I froze for a second and I said, I thought to myself, what my patients are experiencing and what I experienced in childhood doesn't feel personal. These are social problems, right? See what I'm putting down? So, I'm not going to spend a lot of time on the neurobiology today. I think you guys got a great lesson in neurobiology and you're probably a little bit sick of hearing brain science at this point. But I want to do a somatic exercise to understand a little bit about trauma and addiction. So I want you guys to just think for a second about how if there was a cop in the rearview mirror, you were driving down the street, walking down the street, all of a sudden, cop in the rearview mirror, how would your body change?
doesn't change, I freeze.
You freeze. It doesn't change, you freeze. Okay, so we've got freezing over here. How many, and just for the sake of time, how many of you guys feel your heart rate increase? All right. I know it's kind of personal, but sweaty palms. Yeah? Okay. So we've got a lot of physical changes that happen, somatic experiences. But what I want you guys to focus on here is how your brain changes. How many of you guys notice that you have cognitive shifts in these moments? How many of you guys feel like you can't think quite as clearly? Okay, great. So it wouldn't be fair to show this slide and not connect this to structural violence, because I put the slide up and oftentimes there's laughter and we talk about this being stressful, but I just want to be really clear here that for some folks, this image isn't laughing matter, right? This is a really serious life or death interaction, potentially. But let's go back to that cognitive functioning. So for those of you that are medical providers or social workers, when I said, did your cognition change? How many of you guys thought about executive functioning? So that's what we're talking about, right? In these periods of stress, our executive functioning decreases, which is exactly what Dr. Hart said earlier. So what do we lose? And if you want to call out some answers, that's fine. They're already up on the screen. So what do you lose when you get decreased executive functioning? What are some of the skills that you lose?
Ability to think, ability to decision-making.
So decision-making, complex decision-making. What else do you lose?
Your
Ability
ability to focus.
to focus.
Ability to think about long-term impacts of your decisions.
Ability to think about long-term impacts of your decisions. So you become more impulsive, right? Okay. Yeah, this is fight or flight. Exactly. What we're talking about is fight or flight. And so when people have a history of trauma, this is often the norm. In clinical terminology, we call this hypervigilance. But so many people that have a history of trauma, especially if it's chronic and in childhood, there are brain changes to the hippocampus and the amygdala, where this experience of a cop in the rearview mirror is an everyday experience. So then what does it mean for that first oxycodone when you take it and suddenly you feel normal and you think you want more? How would that transform given potentially a decrease in executive functioning? Just sit with that for a little bit. So some more connections. So what we just talked about is that decreased cortical functioning and executive function impairment. We see that in trauma. We also see that in substance use disorders. And the way that we're thinking about this in trauma-informed care is that decrease in executive functioning that happens in the context of trauma and stress is one of the things that gives rise to substance use disorders. If you're not able to really think about sort of historical implications for what you're about to do or to curb your impulses around use, that's one of the ways in which people get caught up in this. The other way in which people get caught up in this is I want you to think about, cop in the rearview mirror, think about your somatic experience. What's the fastest way to get it to go away? What's the quickest, easiest, potentially cheapest way? Let's say you don't have a lot of economic resources. Any guesses?
Use a substance.
What's that?
To use a substance.
To use a substance. So sometimes people will say, oh, deep breathing. And to which I say, so someone taught you skills. But let's say that never in your childhood, and potentially never in adulthood, someone sat down and taught you skills on how to soothe your central nervous system. The cheapest way to soothe the central nervous system that feels out of control is a 6-pack of PBR. It costs about $5, and it's at the corner store, right? So you've got this central nervous system that's out of control. You've got impulse control issues, and suddenly central nervous system depressants are literally your best friend. We talked a little bit about the dopamine decrease that we know or we think happens with high ACEs scores in childhood. And then finally, so this is my super quick overview of the neurobiology of these two things connecting. Finally, you know, the part of your brain that decided to have a somatic response to a cop in the rearview mirror, anyone know what part of the brain that is?
Amygdala.
Amygdala. That amygdala decides whether you're going to have a fight or flight response to something or not. It's both incredibly smart, because you know when you have like a gut feeling about something, it's the amygdala telling you, hey, something's off, and at the same time, it's really dumb. It's an overgeneralizer, so just like my toddler, the amygdala thinks anything that looks mildly stressful is a stressor and will tell you to stress out until your executive functioning comes on and says, hey, don't stress out about that. That amygdala, very, very densely populated with, hey, guess what? Opiate receptors. Which means opiates are that much more powerful when you have a central nervous system that's dysregulated. So I think that changes our conceptualization of what substance use disorders are. We used to think that they were this hedonistic activity where people wanted to feel a lot more pleasure. And actually, in trauma-informed substance use services, the way we conceptualize this is that substance use disorders are about comfort seeking, they're ritualized and they're compulsive, and ultimately they're a skill that people use to soothe this sort of out of control central nervous system. No longer do we think this is a choice, no longer do we think that this is bad morals. Instead, we build on the disease model and say this is a disease that happens generally in a very specific context. How am I doing on time? What? Oh, really? Oh man, I could have spent like so much longer on neurobiology. So sorry. Okay. Yeah, we'll fill the time. Don't worry. All right, so I want to talk a little bit about trauma-informed care then. And because we have time, I didn't sort of go through some of the core tenets and values of trauma-informed care. How many of you guys feel like you know those core tenets and values pretty well, like the SAMHSA definition of trauma-informed care? Oh gosh, not a whole lot of you. Okay, well, so then I don't have a slide for this, but let's talk about some of the key tenets of trauma-informed care, specifically in the context of SUDS, and then we'll move on to sort of some of the systems stuff. So trauma-informed care, and Dina said this so beautifully earlier, trauma-informed care asks that we transform our systems to feel safer that have experienced trauma. I want to just think for a second about the clients. Thanks. Just think for a second about the clients who in childhood experience neglect, sexual abuse, physical abuse, and move into adulthood potentially as IV drug users. I want us to think about what kinds of systems they would feel good walking into. How many of you feel nervous when you go to the doctor, even if, or otherwise provider, even if you yourself are a medical provider? It's still a little bit stressful, right? I'm a medical director, and I still worry that when I go see my doc at Kaiser, they're going to lecture me about my health behavior. I still worry about judgment. So I want us to think really, really, and just spend some time with it today. What do we do to transform services so that people who feel incredibly marginalized and stigmatized by their behavior, by their past, what do we do to make services really welcoming and safe feeling for those people? So there are some things that SAMHSA has identified. I don't know if I'm going to be able to come up with them off the top of my head, but basically collaboration. So one of the things that we do in trauma-informed care is we do a lot more we are more attentive to being collaborative with patients versus telling patients how and what to do. That's one of the key things. I'm now down to 10. Okay, great. So we do a lot of collaboration. We also pay attention to gender issues, historical trauma issues. We think about trauma, and I sort of touched on this earlier, but we don't necessarily just think about trauma in the context of a personal experience. We think about trauma in a much larger context of what's happening socially for people. So we'll talk about historical trauma. Did I already say that? We'll talk about income inequity, gender inequity, et cetera, in the context of trauma-informed care. The other thing that is unique in trauma-informed care, and this is specific to substance use disorder services, but we do consistent praise and validation, even if people are struggling with, by the way, they're continuing to struggle with the symptoms of the disease that they're asking us for support with, they still get praise every time they come into services because we're happy that they're engaging with services, period. So someone's not necessarily meeting the goals in their initial assessment in substance use disorder treatment. We just say, hey, thanks for coming in today. So every interaction with a service provider becomes centered on rewarding behavior, because rewarding interactions also bump up that dopamine level. So every time we say, thank you for being here, I'm so glad that I'm connecting with you today, that's deeply trauma-informed, because we know what trauma does to dopamine levels. So that highlights just a couple of sort of the core tenets of trauma-informed care. But again, the overall umbrella of trauma-informed care is that we're saying we understand the prevalence of trauma in terms of who presents into our services, and then we're doing everything we can to transform the systems to be more inviting for those people. And yet, trauma-informed care and trauma-specific care are different. Trauma-informed care means we change systems. Trauma-specific care means we treat PTSD or trauma sequelae in an individual. Make sense on the difference there? Okay, great. So now, let me jump in and talk a little bit more about some things that I think systemically need to be done to make substance use disorder services more trauma-informed, some things beyond some of those minutiae that SAMHSA talks about. We need lower barrier access to medication-supported recovery. Because of what we know about trauma and dopamine, and what we know about dopamine in the context of all of the substance use disorders, we ensure that best practices, which includes medication-supported recovery, are available to everyone and low barrier. And you guys will notice that I'm using some terminology here that you maybe haven't heard before, medication-supported recovery. People often talk about this as medication-assisted treatment. I've been moving away from that language for a little while now, because this is about recovery. It's not something that I do for you solely in the context of treatment. This is about transforming a life. And I'm going to support you in transforming your life. I'm going to support you in transforming your life with a prescription medication. And yet, this goes well beyond assisting your treatment. This is supporting recovery. Does that make sense in the difference? I also think that potentially a good way to talk about this is to just say pharmacotherapies for substance use disorders. Like, let's just call them what they are, because also some people don't want to do recovery. Some people don't want to have a spiritual transformation. They just want their opiate use disorder to be in control so that they can hang out with their kids again. So pharmacotherapies for addiction is probably the way we should be headed here, and yet I find that medication-supported recovery and talking about it in that way is really useful for a lot of people. Because, by the way, medications don't interrupt your ability to have a spiritual transformation. Meds are not going to meditate for you every day, they're not going to exercise for you every day, they're not going to work a 12-step program for you, but they may make all of those things possible to do, so that the symptoms of your disease aren't totally overwhelming. So we need to make sure that people have access to these medications, and it's immediate and it's low barrier. So right now, people show up at your local hospital system for an OD, let's say, and what happens to them? They're potentially given a list of referrals to some recovery services, some of which are going to provide medication-supported recovery and some of which are not going to provide that. And then they're told emphatically not to do it again, right? Would we ever do that for someone that comes into an emergency room for a heart attack? Give them a list of referrals to some nice cardiologists, and they can just follow up when they feel like it. And then we'll just tell them, please, no more heart attacks. You're really expensive. We would never do that. We would make cardiology treatment immediately accessible and low barrier, and we would do the work for them, right? That's what needs to happen with medication-supported recovery. And people need to have access to medication-supported recovery regardless of whether they continue to struggle. It doesn't mean that maybe they don't need to be in a higher level of care like daily dispense, but gone are the days where people still use heroin and we say, well, this medication's not working for you, we're gonna take it away. Instead, we increase your level of care and we recognize that as long as you're in services, you're safer than you're not in services. And that your risk of overdose goes down tremendously if we keep you on your Suboxone. So that's what I mean when I say low barrier access to medication-supported recovery. I also think that a big part of really making substance use disorder services trauma-informed is including peers. Peers are the true experts in this experience of addiction. I have a history of addiction. At this point, it's remote. My drug of choice was alcohol. I don't really know squat about opiate use disorder. I really don't. I have been doing this work for a couple of years now, but I can't actually sit and know what that feels like. So one of my favorite peer moments is when I started in this work and a patient hadn't shown up for a script for a couple days for Suboxone. And then it was like, 5:01 on Friday night. You guys all know this 5:01 on Friday night phone call, right? It's like classic. So hasn't shown up for their script, 5:01 on Friday night. Hey, I've been really sick. I had the stomach flu, I think. I need a script. And I was like, nope, I'm going home. I've got a kid. This is a boundary for me. And the peer said, hey, have you ever been in opiate withdrawal? Have you sat in that experience? Because, hey, guess what, Lydia? It's traumatic, and I know that's your thing. You're really into trauma. Opiate withdrawal is actually traumatic. And it turns out that the neurohormonal landscape of a PTSD trigger and opiate withdrawal is exactly the same. And I remember that moment so clearly because I thought to myself, I would never have been able to think in this way and be this trauma-informed. And then we did some collaborative problem solving, so the client never called again on a Friday afternoon at 5:01 p.m. We did that in the future after the risk of withdrawal was addressed. And it was because of the peer that went the way that it went. Because I wouldn't have really got that. I would think like, well, you can buy some Suboxone on the street, or like, you'll figure it out, like you've got resources and skills. And the peer was like, no, absolutely not. Lydia, here's what's gonna happen. So peers are essential. And then here's where things might get a little bit controversial, harm reduction. I've actually been talking about harm reduction throughout this entire slideshow. I've mentioned a number of things about keeping people in services, giving them reward for whether they're meeting their stated goals or not. All of those things are basic harm reduction, and yet I want us to start using that language. People are often afraid to talk about harm reduction because what it sounds like is that the only thing we're going to offer you is Narcan, and you're going to have to fend for yourself around your disease of addiction. Or the only thing that we're going to offer you is clean needles or a safe injection site. But I want us to think about it a little bit differently, because to me, harm reduction and treatment, they're just the same things on a spectrum. They're about getting people engaged, giving them persistent, respectful, rewarding interactions with service providers. And the more persistent, rewarding interactions we have with service providers, the more likely people are gonna want to be to engage in recovery services and to have self-respect. So there's a woman on the East Coast who talks about harm reduction as building your appetite. So harm reduction, you start coming into services, you start living a slightly safer life, you start changing some behavior to be slightly safer in your use. That builds your appetite over time to the point where someday you're gonna have a hunger for self-respect, which is gonna ultimately encourage you to get into recovery. So harm reduction and treatment, not two opposing ideas. Harm reduction and treatment are one thing on a spectrum. And right now, in the midst of an opiate epidemic, although I would say that for certain communities, we've had an opiate crisis for a long time, we're just now talking about it, mostly because it's happening to white folks now. I would say that in the midst of an epidemic, we will do everything we can to make people safer and to get people more engaged in services. Even if they're sometimes still engaging in behavior that doesn't align with what we want them to do. We care that they're safer on a daily basis. So I'm potentially leaving you with the most controversial aspect of the talk.